Dr. Carter, and thanks, Dan. I appreciate those thoughts. Just to echo some of the words that have been said, uh, really, phenomenal work by PHEN and the work that, the organization continues to do to ensure that we create awareness and education in our community to promote prostate cancer screening. As we'll hear over and over today, prostate cancer really saves lives. I serve in the NCCN guidelines committee. So the recommendations I'll be sharing with you today are those that were formulated by this panel. And you'll immediately notice that a lot of them are similar between the NCCN guidelines and what Dr. Barroca has just presented for the American Urology Associations. A couple of disclosures here that have no relevance to the talk that I'll be giving today. I will disclose I serve on both the AUA and the NCCN Prostate Cancer Early Detection Guidelines Committee. A talk about prostate cancer screening is never complete without talking about the burden, but you've already heard this over and over today by, from Dr. Crawford, from Dr. Barroca, that prostate cancer really is the leading cancer diagnosis among Black men. It is the second leading cause of death among Black men. And when you compare prostate cancer with other cancers, and you also compare prostate cancer incidence and the risk of dying from prostate cancer with non-Hispanic whites, it is estimated that 1 in 6 men, Black men, will develop prostate cancer compared to 1 in 8 for non-Hispanic whites, and 3.8, about 1 out of 26 men, Black men, will die from prostate cancer compared to 1 in 44 non-Hispanic white men. Despite the controversy surrounding prostate cancer screening, as already mentioned, prostate cancer does save lives. This is one of my favorite slides that really highlight the benefit of prostate cancer screening. When it was introduced in the 1990s, you notice that there's been a sharp decline in the incidence of metastatic prostate cancer, or prostate cancer that has been spread. It has been reduced by about 50%. And when you compare that with mammography screening, there has really not been any significant decrease in the incidence of metastatic disease, at least about 10 years ago. How about dying from prostate cancer? Same. Death from prostate cancer has been reduced by about 20%. Of course, we cannot attribute all of this to simply prostate cancer screening, but screening and early detection really is a huge component of it. So I'm a big proponent of prostate cancer screening, targeted prostate cancer screening. So what I'll present now would be the guidelines that were put together by the NCCN guideline. These guidelines are updated every year. We're currently actually in the process of updating the guidelines for next year. So for 2023, these are some of the guidelines that we came up with, but I'll highlight 3 guiding principles that we use to come up with this guideline. One is that we need to maximize the detection of prostate cancer that that would be treated effectively, or that can be treated effectively, and that if left untreated will represent a risk to the patient. With that in mind, the Prostate Cancer Guidelines Committee or panel supports an early detection program only in healthy patients. A patient that is going to die from something else that is unlikely to benefit from prostate cancer screening, there will be no need to initiate or continue prostate cancer screening. A second principle is the need to minimize unnecessary procedures and limit the detection of indolent disease or low-risk prostate cancer that will not harm the patient. And Dr. Barroca has already touched on this. Our goal really is to detect aggressive prostate cancer that would cause harm if untreated. A third principle, I think this is really important, and this was also very well highlighted by Dr. Barroca in the AUA guidelines, is the fact that patients, you as a patient, need to be very involved in making this decision. These guidelines are exactly what they are, guidelines. They do not stipulate what needs to be done, but they are there to guide patients and physicians, and physicians are still expected to use their independent medical judgment in consultation with the patient to make decisions on how to apply these guidelines, how to initiate and how to effectively screen for prostate cancer. So this is the algorithm, very busy slide. So what I'm going to do in the next few slides is to highlight the different statements and how they may apply to you personally. And you'll notice that some of them are very similar to the AUA guidelines as well. So first, when should we initiate testing, PSA testing for screening for prostate cancer? Overall, the recommendation is at 45 years. Why? This is based on data that indicates that baseline PSA at 45 strongly predicts lethal prostate cancer. That is prostate cancer that is likely to harm a patient. So if the baseline PSA testing is PSA test is 1 or more at age 45, then that indicates that that patient is likely to develop an aggressive form of prostate cancer. So repeat testing at 1 to 2 year intervals is recommended. But if PSA at 45 years of age is less than 1, then repeat testing at 2 to 4 year intervals is recommended. Why? Because that patient is unlikely to develop high-grade or clinically significant prostate cancer. What if you're 50 or 60, never had a PSA? It's not too late. You can get a PSA. Individuals that are 45 to 75 years getting their first PSA, if their PSA is less than 1, then you can go to the 2 to 4 year intervals. Again, the intervals or the ranges there for you to be able to have a conversation about your risks and benefits with your physician to determine what is appropriate for you. If PSA is between 1 and 3, then repeat testing at 1 to 2 year intervals may be needed. What if your PSA is more than 3? Then further risk stratification or continuing to monitor the PSA may be indicated. Again, that would have to follow a conversation between you and your physician. All right, so you've been having PSA testing. When do you stop? Well, in general, when life expectancy is less than 10 years, that patient is unlikely to benefit from prostate cancer screening. Why? Because that patient is unlikely to die from prostate cancer. So the general guidelines or age limit that we put in the guideline is that continuing PSA screening at the age after the age of 75 should only be performed if that patient is very healthy with little or no other comorbidity or other illnesses that could potentially harm the patient. For example, a patient who is 75 with severe heart disease, diabetes, who is unlikely to die from prostate cancer will not benefit from prostate cancer screening. But someone who is 75, whose mom is still alive at the age of 95, may benefit from continuing on prostate cancer screening. Individuals who are 60 years or older with a PSA of less than 1 may safely discontinue PSA screening, and that is because the likelihood of them developing prostate cancer that will harm them is very low. Individuals who are more than 75 years of age, whose PSA is less than 3, could safely discontinue PSA screening, again, because the likelihood of developing high-risk prostate cancer is also very low. And I think I made this point somehow already, that if someone is more than 75 years, but with normal PSA or normal prostate exam, such an individual can continue PSA screening if they're interested. But again, you'll have to follow a conversation with your physician to make sure that it will offer some survival benefit. And here's the next portion of our guidelines is really focused on high-risk populations. And this has already been mentioned. Blacks or African Americans are at high risk of developing prostate cancer in general. They are at high risk of developing aggressive prostate cancer. They are at high risk of dying from prostate cancer. And as already mentioned, screening data is lacking in our patient population. So it is really, really important that we promote screening in Blacks and African Americans because they are high risk. Another group is patients with family history, a first-degree relative, especially if they develop prostate cancer at an early age, and patients that have a number of mutations or alterations in their genes that put them at risk of developing prostate cancer. Now, how should screening be done in this patient populations that are considered to be high risk? For Blacks and African Americans, we recommend baseline testing at 40 years. There's some data, though, that suggests that 40 or 45 years will be okay. But again, this data is primarily in Caucasians, as highlighted by Dr. Barocas. But we believe that a baseline age of 40 years is a safe way to start. However, if a patient has a strong family history, a first-degree relative, then you want to start the screening 10 years prior to the age of the youngest person in the family to be diagnosed with prostate cancer. What does that mean? If someone has a brother who is 45, diagnosed with prostate cancer, they may want to start screening at about the age of 35. As you saw from Dr. Crawford's presentation, in 30s, Black patients could have at a higher risk of developing prostate cancer compared to non-Hispanic whites. And the same recommendation is for patients with mutations that may put them at risk for prostate cancer to start screening at 40 years. Mm-hmm. Now, what if your PSA is elevated and then you're considering what to do about that? Dr. Barocas highlighted what the algorithm is. Again, very similar with the NCCN. We recommend repeat PSA, a prostate exam if it has not been done. And we also strongly recommend an MRI. And the reason is because MRI improves our ability to detect clinically significant or aggressive prostate cancer that needs to be treated. And of course, if the decision between you and physician is to proceed with a prostate biopsy, there are different techniques or strategies that could be implemented. But also mentioned here is biomarkers. Again, same with the AUA guidelines, biomarkers should be considered if it will improve the specificity of screening. In other words, if it will change what decision you or your physician decides to make regarding a screening or a biopsy. And this is important because, as already mentioned, there are a lot of biomarkers that are out there. Of course, PSA is still the mainstay of screening for prostate cancer, but there are other biomarkers. Dr. Barocas mentioned percent free PSA. There are other blood tests like PHI or 4K score, a number of urine tests. And then for patients who have a previous biopsy, there is a tissue-based test called Confirm MDX. It's important that you're aware of some of this tests and have a conversation with your physician to determine what may be appropriate for you. And this is important because in this model published by Dr. Nyame, who you will hear from as part of this program, highlights some of the different areas where inequities in early detection come into play. And what I would like to point your attention to here is access to MRI and access to biomarkers. And I added biomarkers to this slide because, as I will show you, a number of biomarkers that have been developed for prostate cancer early detection may improve detection of prostate cancer. But the challenge is that either they've not been well studied in African-American or Black patient population, or they're not completely studied at all. And why is this important? Some biomarkers may not do well in Black patient population. For example, we know that Black patients tend to have a gene expression level of a gene called ERG that is lower compared to his non-Hispanic whites. And two of the tests here, urine-based tests, actually a key component of them is ERG. And I'm ashamed to say that I'm from the University of Michigan, and one of these tests that we actually, that was developed here called the Michigan Prostate Score, incorporates ERG, but ERG actually has a lower expression in Black patient population. And currently we're working to try to optimize this test by including other biomarkers that have better performance in Black patient population. I think that, I'll kind of like, close with this slide. We've made significant progress when it comes to deaths from prostate cancer, beginning in the 1990s to now, 2020. Shown in red is the death rates in Black patient population. You can see the decline since PSA screening was introduced. Similarly, there has been a decline in deaths from prostate cancer in the white patient population, shown in blue. But you notice that there is a gap, there is a difference. When you calculate the ratio between the death rates in Black patients and white patients, shown in black, they have stayed relatively stable, the same. We are now moving the needle within the disparities. So we need to continue to work to promote prostate cancer screening, develop strategies to target the detection of aggressive prostate cancer screening for treatment. So my concluding thoughts are that Blacks are disproportionately impacted by prostate cancer. We've talked about that today. Everyone knows that. We also know that screening and early detection strategies should be targeted towards identifying aggressive disease, and we need to do everything that we can to continue to promote that. Screening saves lives. And this is the group that put these guidelines together, and I'll stick around to take any questions. Thank you for listening.